Somewhere in a research building in the United States, right now, a small group of scientists is working on something that sounds almost impossible. They are trying to end the need for cataract surgery, not by making the surgery faster, not by making it safer, but by making it disappear altogether. And if what they are testing actually works the way early data suggests, then millions of people who assumed they would eventually go blind from clouded lenses may never have to face that fear again. I want you to sit with that for a second. Because for over 100 years, there has been exactly one accepted solution for cataracts. You wait. You watch your vision slowly fog over, like looking through a dirty window that gets a little dirtier every year. Colors fade. Night driving becomes terrifying. Reading becomes exhausting. And eventually, when it gets bad enough, a surgeon cuts open your eye, breaks up the clouded lens with ultrasound, vacuums it out, and slides in an artificial replacement. It works. It is one of the most common surgeries on Earth, but it is still surgery. It still means someone cutting into one of the most delicate structures in your entire body. Now, a new trial beginning in the United States is asking a very different question. What if you didn't have to wait for the damage to happen at all? What if there was a way to stop the clouding before it ever started, or even reverse it once it began, using something other than a blade? To understand why this matters so much, you have to understand what a cataract actually is, because most people get this wrong. A cataract is not a growth, it's not a tumor, it's not an infection. It is a slow chemical betrayal happening inside a part of your body that was never designed to repair itself. The lens of your eye is unlike almost every other tissue you have. Every other part of you is constantly turning over. Your skin replaces itself, your blood cells replace themselves, even parts of your liver can regenerate. But the proteins inside your eye's lens are largely the same proteins you were born with. They don't get replaced. They don't get recycled. They are asked to stay perfectly clear, perfectly folded, and perfectly aligned for 80, 90, sometimes 100 years. Think about how remarkable that actually is. You have proteins sitting inside your eye right now that are the exact same age as you are. No renovation, no replacement parts, just the original material, expected to stay flawless for an entire lifetime. And for a long time they do. In childhood, in your 20s, your 30s, even your 40s, those lens proteins hold their shape with astonishing precision, arranged in a way that lets light pass through without scattering. That precise arrangement is the entire secret to clear vision. The moment those proteins start to lose their shape, the moment they begin to unfold even slightly and clump together, light starts to scatter instead of pass through cleanly, and that scattering is what you and I call cloudiness. This is where it gets interesting, because the process that causes that clumping is not some rare disease. It's not bad luck. It is oxidative stress, the same slow, quiet damage caused by free radicals that affects nearly every tissue in your body as you age. Every time your body burns oxygen, it also generates unstable molecules that can damage nearby structures. Your body has defense systems to mop up this damage, but your lens sits behind your cornea, largely walled off from a fresh blood supply, which means those defense systems have a much harder time reaching it. Over the decades, that damage accumulates, and because those proteins never get swapped out for new ones, the damage never gets erased. It only builds. So a cataract isn't really getting an eye disease the way we normally think about disease. It's decades of accumulated oxidative wear finally crossing a visible threshold, which raises an extraordinary question. If the underlying cause is oxidative damage to proteins that never renew themselves, what happens if you could interrupt that damage early? Or better yet, what if you could chemically help those existing, misfolded proteins refold back into their original clear shape? That second idea, refolding damaged proteins back into shape rather than removing them, is exactly the territory this new trial is stepping into. And it is a genuinely strange, genuinely exciting shift in how medicine is starting to think about aging tissue in general, not just the eye. For decades, the entire model of treating a damaged, non-renewing tissue was simple: cut it out and replace it with something artificial. That's cataract surgery. That's a hip replacement. That's a heart valve replacement. Remove what's broken, install a substitute. It works, but it treats the body like a machine with interchangeable parts, rather than a living system that might, under the right chemical conditions, be coaxed into repairing itself. The compounds now entering testing take a completely different approach. Instead of replacing the lens, they aim to interact directly with the misfolded proteins already sitting inside it, encouraging them to unfold their tangled clumps and refold back into a clear, organized structure. It sounds almost too elegant to be real. You take a lens that has spent 20 years slowly clouding over, and instead of removing it, you introduce something that helps push those very proteins back toward the shape they were supposed to keep all along. If that approach proves out in this new trial, the implications go far beyond just fewer cataract surgeries. Because remember what we said earlier, this is one of the only tissues in your body made of proteins that never get replaced. If scientists can prove that non-renewing, aged proteins can be chemically coaxed back into proper shape once they've misfolded, that is a proof of concept with consequences reaching into other aging tissues throughout the body, tissues that also rely on long-lived proteins holding their structure for decades. This isn't just an eye story. It might be an early chapter in a much bigger story about aging itself. Now, before we get carried away, let's slow down and be honest about where things actually stand, because there is a meaningful difference between early trial beginning and cure available now. A trial beginning in the United States means researchers are moving into a phase of testing this approach carefully, methodically, in real patients under real safety monitoring. That is a serious, exciting milestone, but it is also, by definition, the beginning of a process, not the end of one. Trials exist precisely because we don't yet know the full answer. We know enough to believe the idea deserves rigorous testing. We do not yet know, with full certainty, how consistently it will work, for whom it will work best, how early cataracts need to be caught for this approach to help, or what the long-term safety profile looks like across thousands of people over many years. That uncertainty isn't a weakness of the story. It's exactly what responsible science is supposed to look like. Skepticism paired with real hope is a healthier place to stand than blind excitement. So hold both of those at once as we keep going. Genuine excitement about the mechanism and genuine patience about the process. Let's talk about why cataracts deserve this level of attention in the first place, because the scale of this problem is honestly staggering, and most people have no idea how big it really is. Cataracts are the leading cause of blindness worldwide. Not one of the leading causes, the leading cause. More than any infection, more than any injury, more than any other single condition. And it isn't a rare misfortune that happens to a small, unlucky group of people. It is closer to a universal outcome of simply living long enough. If you live into your 70s and 80s, some degree of lens clouding is closer to the rule than the exception. Your risk doesn't spike suddenly. It climbs steadily, quietly, for decades before you notice anything at all. And the burden isn't evenly distributed around the world. In countries with strong access to surgical care, cataracts are treated as an inconvenience, uncomfortable, disruptive, but ultimately fixable with a same-day outpatient procedure. In countries where access to surgeons, operating rooms, and follow-up care is limited, the exact same biological process instead leads to permanent blindness. Millions of people are not blind because their condition is untreatable. They're blind because the treatment that exists requires infrastructure they don't have access to. This is precisely why a non-surgical approach, even an imperfect one, even one that only slows or partially reverses early clouding, could matter enormously beyond wealthy countries with abundant surgeons. Imagine a treatment that could be distributed as eye drops or a simple outpatient injection, administered by a broader range of trained healthcare workers rather than requiring a specialized ophthalmic surgical suite. That is a fundamentally different scale of accessibility than a procedure that depends on operating rooms, anesthesia, and surgical training. It's the difference between a solution available to whoever can reach a major hospital and a solution that could realistically reach far more of the world. Let's also talk honestly about what current cataract surgery actually involves, because I think most people underestimate both how impressive it is and how much of a burden it still represents. Modern cataract surgery is, in a purely technical sense, remarkable. Surgeons use a technique called phacoemulsification, using high-frequency ultrasound to break the clouded lens into tiny fragments, then gently suctioning those fragments out through an incision smaller than 3 millimeters. An artificial lens, folded to fit through that same tiny opening, is then inserted and unfolds into place inside the eye. In skilled hands, the entire procedure often takes less than 15 minutes. Recovery for many patients is measured in days, not weeks. It's one of the great success stories of modern medicine. But impressive and no big deal are not the same thing. This is still an invasive procedure on one of the most sensitive structures in the human body. There is still a real, if small, risk of infection. There is still a real, if small, risk of retinal detachment. There is still the disruption of taking time off work, arranging transportation because you can't drive yourself home, using medicated eye drops multiple times a day for weeks afterward, and returning for follow-up visits to make sure everything is healing correctly. For a healthy adult with good access to care, that's manageable. For an elderly patient with other health conditions, for someone without reliable transportation, for someone in a region with a shortage of ophthalmic surgeons, that same minor outpatient procedure can become a genuinely difficult barrier to overcome. And that's exactly the gap this new research is aiming at. Not necessarily to make surgery obsolete overnight, but to create another option, especially for people caught in that earlier window, before their cataracts have progressed to the point where surgery is the only remaining choice. So let's go a layer deeper into the actual mechanism, because I think this is where the story becomes genuinely fascinating rather than just hopeful. The lens of your eye is made up overwhelmingly of a family of proteins called crystallins. These proteins are packed together with extraordinary precision, arranged in a way that allows light to pass through without scattering, almost like a perfectly ordered crystal, which is exactly where the name comes from. As oxidative damage accumulates across decades, some of these crystalline proteins lose their correct folded shape. Once a protein unfolds even partially, it becomes sticky in a sense, prone to clumping together with other damaged proteins nearby. Those clumps are large enough to scatter light, instead of letting it pass through cleanly. Enough scattering, spread across enough of the lens, and you get the cloudy, hazy vision we call a cataract. For a long time, the assumption in the field was that once those clumps formed, that was essentially the end of the story for that patient's natural lens. Removal and replacement was the only way forward, because there was no known way to convince already clumped proteins to let go of each other and refold correctly. What's changed is the discovery of certain small molecules, compounds that appear able to interact directly with these misfolded clumped proteins and encourage them to release from each other and refold back toward their original, clear configuration. Early laboratory research, including work in animal models, has shown measurable improvements in lens clarity after exposure to these compounds. That early signal is what has justified moving into carefully controlled human trials, the stage now beginning in the United States. It's worth pausing on how unusual this is as a category of medicine. We are used to drugs that block something, drugs that boost something, drugs that kill something like bacteria or cancer cells. A drug whose entire mechanism is helping an existing protein fold back into its correct shape is a much newer and rarer category. If this approach is validated here, in the lens of the eye, it opens conceptual doors toward other conditions defined by protein misfolding, a category of disease that includes far more than cataracts. Now let's talk about what this new U.S. trial specifically is trying to establish, because trial beginning can mean a lot of different things depending on the phase, and it matters to understand what stage we're actually at. Early phase trials like this one are primarily designed to answer two central questions before anything else. Is it safe, and does it show a measurable biological effect? Researchers will be watching closely for any adverse reactions, irritation, inflammation, unexpected changes in eye pressure, or any signal that the treatment is causing harm rather than helping. At the same time, they'll be measuring whether patients show any objective improvement in lens clarity, using standardized imaging and vision testing to track changes over the course of the trial, rather than relying on how people simply feel their vision has changed. This phase typically involves a relatively small, carefully selected group of participants, closely monitored, often starting with patients who have earlier stage cataracts rather than advanced ones, because if a treatment is going to show a meaningful effect, it's most likely to show it in tissue that hasn't already progressed too far. That's an important detail, because it tells you something about how this treatment, if successful, would likely first be used in the real world. It probably wouldn't replace surgery for someone with dense, advanced cataracts overnight. It would more likely become a new frontline option offered early, potentially years before surgery would otherwise have been necessary, with the goal of slowing, stabilizing, or partially reversing clouding before it reaches the point where only surgical removal will do. If this early trial goes well, it would typically be followed by larger trials involving more participants over a longer period, testing the treatment across a broader range of ages, cataract severities, and health backgrounds before any regulatory approval could even be considered. That is a process that, historically, tends to take years, not months. So, even in the most optimistic, realistic scenario, this is not something arriving in clinics next year, but beginning a rigorous human trial is still a meaningful, concrete step forward, the kind of step that, decades from now, people may look back on as the real starting point of a shift in how this disease gets treated. Let's zoom out for a moment because I think there's a bigger pattern here worth noticing, one that goes beyond cataracts specifically. For most of medical history, our default response to age-related tissue damage has been replacement. Hips wear out, replace them. Heart valves calcify, replace them. Lenses cloud, replace them. That approach has saved and improved an enormous number of lives, and it's not going anywhere anytime soon. But increasingly, researchers across many fields are asking a more ambitious question. Instead of only replacing damaged tissue after the fact, can we intervene earlier, at the molecular level, and help the body's own structures maintain or even restore their original condition? That shift in thinking touches far more than eyes. It touches how researchers think about the accumulation of misfolded proteins in the brain associated with certain neurodegenerative conditions. It touches how researchers think about stiffening blood vessels, damaged cartilage, and other slow accumulating structural damage that builds across a lifetime. Cataracts happen to be one of the clearest, most visible, most measurable examples of this kind of damage,